David Ellington is going to give us a talk. He's on the editorial board of the CPT code book. And when David and I met today, he says, I'm an LMD. And he said, do you actually know what an LMD is? And I said, I'm much older than I look, and I actually do know. You're a local medical doc. So I'm really pleased to introduce David.
Thank you, Howard. Well, that stole my punchline of what I am, and I look out there and I see a few other LMDs in the audience. I originally thought when I was asked to do this that all I had to do was just explain to you how we arrived at the transitional care codes and the chronic complex care coordination codes. But then I got the instructions from Catherine and I said, well, you're supposed to tell us in 100 words or less what excites you. And then tell us, you know, what's exciting about the CPT panel. So what excites me, I can do in 2 words. The first one is a rather prosaic article, okay, not very exciting. But the second one ought to excite everyone in this room, and that is the profession. And that's the thing that gets me up in the morning, and that's the thing that excites me. And I'm going to try to excite you about the CPT panel and let you know what it is. As Howard said, I don't teach at a medical school. I'm not the editor of JAMA. I'm an LMD. Many of you know the much maligned, rarely seen, and never admitted to status of the LMD. That's the local medical doctor. And we were when all of us were in medical school, this was usually the presentation, this unfortunate 45-year-old male with uncontrolled hypertension, poorly controlled diabetes, and unstable angina, who is managed by his LMD, presents to the hospital. Well, that's what I do. I had a couple of pictures of an LMD hometown here, and that was all the pictures you were going to see from me today. But that's what I do. But I'm also on the CPT Editorial Panel. CPT stands for Common Procedural Terminology, and this is a group of a little over a dozen practicing physicians, representatives from the payer community, some coding consultants, and 2 non-physician allied health members who make the codes that you see in the CPT coding manual. In other words, what we do is we describe the work that the physician does when he reports it to get paid. And so we describe the what. The ICD-9 and ICD-10 codes that we use prescribe the why. You know, what's the diagnosis that you do it. So we describe the what. And I guess the hardest job I'm going to have to do is to try to explain to you why this is exciting. Someone told me one time that watching the CPT panel was like watching paint dry. And I can assure you that some of the 3 meetings we have each year are the Stanley Cup of watching paint dry. I mean, we debate whether a phrase comes before or after a semicolon, whether an example is preceded by EG or IE, and which exclusionary parentheticals we put at the end of a code to make sure you don't double code for something and try to double dip and get paid twice for one procedure, which guaranteedly is not very exciting. But then I thought about the things that we considered and the things that we looked at over the past year, and these are exciting, even for an LMD. We considered codes describing the work over the past year for transcatheter replacement of aortic valves and mitral valves. Imagine that. You're doing aortic valve surgery and mitral valve surgery and replacement through a catheter with no thoracotomy. That's exciting, I think. Just this last meeting, we considered a code for where you draw blood off of a patient, pherese out the plasma, treat the plasma to change the HDL and change it to an HDL that it'll cause regression of atherosclerotic plaques in the heart. That's pretty daggone exciting. Just this week, the FDA approved a new tetravalent influenza immunization for treating kids 6 months to 3 years of age. Last year at the CPT panel, we approved that code. So that code is already on the book, available for use in the upcoming influenza season. And so now we have a tetravalent, 2 A's against 2 A's and 2 B's, rather than the trivalent. At our last meeting, we considered and talked about a code for recombinant DNA influenza vaccine manufacturing. In other words, when the producer gets the genetic imprint of the influenza virus within weeks, not months, they can use DNA recombinant technology and produce vast amounts of this immunization that's egg-free, antibiotic-free, preservative-free, and specific for that specific influenza strain. That's pretty exciting to me. And then we've opened up the door in the last several years to new molecular pathology. Now, you heard Howard say earlier that in the future we're going to be treating diseases on the molecular basis rather than on the histological basis. And so if you look in a certain section in this MOPATH, or the molecular pathology section of the CPT book now, you will see a whole section that's dedicated to these particular codes, and we accept many of these codes on an ongoing basis. That's pretty exciting because that allows us to do the work that Howard talked about in the future. So what are these things? How do these things excite an LMD? Because I don't do transcatheter valve replacements, and I don't do the delipidation procedures for that. I work mainly in the world of E&M, or evaluation and management. And we've all heard of the segregation in medicine between the cognitive specialties and the procedural specialties. I sort of think that's a false dichotomy because that makes it sound like you got a bunch of guys over on this side who do a lot of thinking but don't do much, and then a bunch of guys over here who do a lot of things and never think about what they're doing. But be that as it may, most of the cognitive specialties, like the LMDs or the family physicians that I am, work in the world of evaluation and management. In July of 2011, CMS sent out their preliminary ruling for the upcoming year, and one of the things that they said was that they wanted a greater concentration on coordination of care of chronic diseases. They were tired of paying a lot of money for that, and they wanted to invest in that. The CPT panel, headed by Peter Hallman, who is a gerontologist, met with the RUC, and we got together and decided what were the things that we needed to do and what were the things we needed to look at. And we decided that we needed to concentrate on two areas. One are called transitional care codes, and the other are chronic complex care coordination codes. So over the next several months, work groups involving 15 or 20 different specialties at the CPT panel, who are our advisors, got together and we came up with these two codes. These were implemented in the 2013 code book that you see. CMS accepted the transitional care code. They told us we needed to do a little bit more work on the other one, and so we've already gone back and tried to adapt the chronic complex care coordination codes. But I'd like to talk to you just in a couple of minutes now about the transitional care codes. CMS this upcoming year has made a $1.34 billion bet that if they pay for these codes, they're going to decrease the amount of money they're having to spend on hospital readmissions. We've all heard the number of 20% of people get readmitted within the first 30 days. There was a study done in February of this year which looked at that based on the Dartmouth Atlas project, and they said, well, it's probably not 20 across the board. It looks like it's about 16% of medical admissions are readmitted, and about 12.5% of surgical discharges are readmitted. But still, over the course of a year, CMS is paying $26 billion for readmissions. And they believe that about $17 billion of that is unnecessary, that it could be avoided. Less than half of people that get discharged from the hospital see their primary care physician within a month after discharge. Those that see them have a 3% readmission rate. Those that don't see them have a 20% readmission rate. And so this is where the focus and the push on the transitional care codes has come in. So what do the transitional care codes do? Well, they say that within 2 working days of after a patient is discharged, that they'll get a call from the office with medicine reconciliation, see that home health is set up, and see if there are any problems. And then, depending on the complexity of the case, though, the patient will be seen face-to-face within 7 or 14 days after discharge. And all of the care coordination over 30 days is then submitted at the end of that time. These codes are already being paid, and they pay very well to the primary care physician. I had a physician who called me last night. He's a delegate at this meeting, and he's going to see me, and he just wanted to tell me that his office and his approach to discharges had changed completely. Absolutely completely, because he said, now I have more of an incentive to do what I really wanted to do but couldn't do before. So we think that the transitional care codes are really, really a game changer, and we're looking for big improvements in that. And so, is that exciting? Yeah, I think that's pretty daggone exciting, and is more exciting than watching paint dry. I saw Ed Hill back there a little bit. There's Ed. Ed was president when I was president of the Medical Society of Virginia, and I went to a number of installations when Ed was the president, and he told the same story several times about Elvis Presley, a local icon in Mississippi and Virginia. And I'm going to use the same quote here that I've used before. And so, Ed, I knew now I know exactly how you felt, because there are only so many quotes to go around. Back in the late 50s, back in the late 40s, at the end of World War II, it was an incredibly pessimistic time. The world had just gone through World War II with all the civilian casualties, the military casualties. We'd begin to discover the impact of the Holocaust. Nuclear armament had just come out, and people were predicting some type of nuclear Armageddon and the end of mankind. That's what they were predicting back then. Well, William Faulkner, who was probably every doctor's nightmare because he smoked too much and drank too much, won the Nobel Prize for Literature in 1949. And so in 1950, he delivered his speech. And Faulkner was an optimist. And what he said, now you have to realize this is 1950s, and so with the pronouns, I hope everybody doesn't get too upset about this. But what Faulkner says, I just don't accept this about the end of mankind. He, meaning the human race, will survive. And he won't survive because he is the only creature with an immutable voice, but he has a soul, and he has a spirit that is capable of sacrifice, it's capable of endurance. And I don't believe that man will merely endure. I believe that he will prevail. It is very gratifying as a practicing physician to work with the CPT panel, the dedicated staff we have, the physicians and the non-physician members, and really the dozens of advisors we have that touch every component of medicine. But it's even more gratifying when this work that is done is on behalf of our fellow physicians and our patients. And the ultimate payoff is that this work that is done is also done on behalf of my profession, which is our profession. And I think it really contributes to the enduring idea that the profession of medicine will not just persevere and will just not endure, but we will prevail. And after all is said and done, that's what makes me excited. So thank you all very much.